So today I want to talk a little bit about quality improvement in heart failure in general, and then specifically spend some time talking about CONNECT-HF, which is a study we're putting together that really builds on the study that Emily referenced, and I'll talk a little bit about that one as well. And my goal is to try to end early and have Linda Davidson-Ray, who's the project leader on CONNECT, join me up here to kind of answer some questions specifically about that study and let you know our thoughts of how that'll be rolled out and next steps moving forward for CONNECT. So that's where the title of the talk comes from, Connecting the Dots. And hopefully we'll finish with plenty of time to talk some more about CONNECT. These are my disclosures. And I've broken the talk up into a couple different areas for today. So first I want to talk about why I think improving heart failure care is really a public health issue more than anything else. Of course it's important for patients, but also just for public health as a whole. Second, I want to provide just my thoughts on where I think heart failure is today in 2016, because it's germane to anything we talk about in terms of quality improvement efforts. And there are some unique things that are happening in heart failure that are extremely relevant to quality improvement efforts. Third, I want to provide a little brief history of some of our previous attempts at heart failure quality improvement efforts. I'll talk about the study we did previously, and then I want to focus a lot on new DCRI initiatives. So first, heart failure as a public health issue. This slide shows the prevalence of heart failure in the United States, and I think it's important to start here for two reasons. One, you can see it's stratified by age across the bottom. So on your right, you can see that most patients with heart failure are 60 years or older. That's important for two reasons. One, if you're trying to envision what a heart failure patient looked like, it's helpful to know what their typical age is, but two, also to think about their insurance, which is often Medicare, as we think about this as a public health issue. It's also relevant as we think about the population aging. We think about the fact that heart failure prevalence is increasing, and that's shown in this next slide here. So on the left, on your left is the projected prevalence out to 2030, as well as the projected increases in direct and indirect costs related to heart failure care. And this growth and the increase in costs is really for two reasons. So one, I kind of already highlighted the fact that the aging of the population. But the second reason is also important. If you think about some of the dramatic improvements we've seen in other areas of cardiovascular care, some of those have been a big part of the DCRI. If you think about improvements in coronary disease or valvular disease or congenital heart disease, those have been great, but often those patients end up living longer with an abnormal heart and as a consequence are living with heart failure. And so those are two of the things that really seem to be driving this increase in prevalence. This second issue here about improvements in other areas of cardiology is shown here. So on the left are hospitalizations for coronary heart disease from 1970 to 2010. And on the right, similar time period, are hospitalizations for heart failure. You can see that you see improvements in coronary disease related to medications and other improvements in care. But we didn't see the same things translate over into heart failure. And you can see this if you look at a couple different measurements, but kind of driving home that point. At the same time, when we think about heart failure as a public health issue, it's important to remember that cardiovascular disease spending still dominates the U.S. healthcare system. So this is a graph from the Department of Commerce. And the blue line across the top is cardiovascular spending specifically. And while it's true that other therapeutic areas have risen faster than cardiology over the last few years, cardiology continues to be the leader by far. This is my last slide here, kind of talking about heart failure as a public health issue. But as you can see that we spend $2.7 trillion annually on healthcare, 18% of our GDP, and that cardiovascular care is expected to be $1 trillion by 2030, and heart failure will make up a significant aspect of that, $71 billion by 2030. So I hope I've laid out a couple things to help you frame this as a public health issue. And my argument for why this should be the first question in the vice presidential debate tonight. We should be talking about heart failure when we have people on stage. So let me move on to the second aspect of this, heart failure care today in 2016. So I'm going to go through each of these figures on the slide, but these are just a couple of my thoughts on what I think are relevant topics in heart failure care, and all of these translate into how we think about quality improvement efforts. So the hand image of the extra pills, there are a number of new oral therapies available for heart failure. It's really exciting to be a heart failure doctor at this time because you have a lot of new options for patients, and I'll talk about some of those. Underneath that is a device, a left ventricular assist device, or an LVAD. There are many new devices both in the electrophysiology world and in the heart failure space to help patients with heart failure. It's really exciting, and the technology is moving very quickly. But when we take a step back and think about quality improvement efforts, often the evidence kind of lags behind of being able to really drive high quality care for those things. The figure at the top is meant to represent the changing epidemiology of heart failure. And I'll get into that a little bit. But if you look at the heart on the right, the thick, stiff heart, that's heart failure with preserved ejection fraction. So almost all the things I talk about are for people with a weak heart. But many more patients now have heart failure with preserved ejection fraction, and we have much less evidence there. So we'll talk some more about that. The last image on here is a screenshot from Hospital Compare. And one of the things I'm going to touch on a couple times over the remaining hour is just the importance of some of the public policy changes that have happened over the last decade. They really dominate QI and heart failure and are an important aspect of how, if you walk into a hospital in America and ask them about quality improvement efforts, they're all anchored around that. So I'll go through each of these images here in some detail. So the first, the hand of pills. This is one of the new oral therapies that's available for heart failure care. And if you don't know this story, it's actually fascinating. So ivabradine is the name of the drug. And it's a drug that lowers heart rate in all patients, but was studied in heart failure in the late 2000s in the rest of the world, but not in the United States. And the top line results are shown in the figure here. So it improved heart failure hospitalizations and cardiovascular death, and is very well tolerated relative to some other heart failure drugs. The data were presented in Europe and published in The Lancet, and the drug was approved in Europe and has been used for the last 6 years. But because no US patients were included, the company never really pursued FDA approval until last year. They partnered with Amgen, and it was approved a year ago with no US patients. And so kind of an interesting story of a drug approval. And I don't know of other ones like that in heart failure. I'm not all that familiar with other ones outside of heart failure, but certainly unique in the heart failure story. So it's one of the new therapies that's available to us today. This is the second one that certainly dominates commercials. When you think about heart failure, we see a lot of information about LCZ696 or Entresto. So these are the top-line results from the Paradigm HF trial. This was another oral therapy for patients with heart failure with a reduced ejection fraction or a weak heart, and really impressive results for cardiovascular mortality or heart failure hospitalization shown here, but also had an effect on all-cause mortality. And it really changed the way that we think about treating patients with heart failure. So two new therapies, again, really exciting. They both came out really over the last year. But as many of you know, driving that evidence into practice has been a problem for a long time. And we see that now when you see the initial reports of uptake of both of these drugs. It's quite low. And this is an image from the Institute of Medicine report that was published in 2001, but the same thing's still true today, that the ability to go from published clinical trials and guidelines for these two drugs into routine practice is extremely challenging. So we'll talk about some of the efforts around that. This is a nice image of some of the changes in mechanical supports. I mentioned left ventricular assist devices. If you look all the way on the left side of the screen, these large devices here, are some of the original devices that help people with a weak heart pump blood around their body. And they're so large that they're surgically implanted and actually sit outside the body. Patients would stay in the hospital. And over the last about 15 years, you can now see on the right side of the screen what these devices look now. They're the size of a AA battery, much smaller. The surgery is much more straightforward. And we're still trying to kind of deal with how we will use these in patients and try to get an evidence base around treating these patients after the surgery has been completed and they're living with this in the community. This figure nicely shows the growth of LVAD therapy nationally. On the left side of the screen is from a registry of these devices. And on the right side are our own Duke data. And you can see there's been a rapid uptake of this for patients with more advanced forms of heart failure. But at the same time, we don't have a lot of great published data of how to handle them when they do come back into clinic. And so a lot of this is really trying to make it up as we go. But it's hard to have a quality improvement effort around these devices or a lot of the other devices that you think of in heart failure, just because the adoption's been so quick. So I think this is, I told you I wanted to provide a little bit of context around heart failure in 2016, and I think this is a nice slide used in many talks, but it really gives you a sense of what it's like to be a heart failure doctor today as opposed to 1989 shown here. There are many other options for patients, which is great, but being able to have the evidence to use them in the best manner is still a challenge. So let me talk about two of the other things that are on here. So one is the changing epidemiology of heart failure. And this is a really important point. So let me show this here. This is a figure that was adopted by something published by Ben Steinberg. You guys remember he was a fellow here. And it's published out of Get With The Guidelines data. So if you look at the solid filled in dots in the red are patients with heart failure with reduced ejection fraction or a weak heart. And you can see their hospitalizations are decreasing over time, and by 2020 are predicted to be less than those with heart failure with preserved ejection fraction. And in fact, if you look in some other data sets, this has already happened. So in the blue are patients with a stiff heart or preserved ejection fraction. And so they're really starting to dominate kind of the landscape of heart failure. And what's important about that are two things. One, that's definitely a disease of the elderly. So patients with a preserved ejection fraction are rarely young patients. They're almost always 65 or older. But two, we really don't have therapies for them. And so this is a figure just to kind of illustrate that all of the evidence that we are going to talk about and all the quality improvement efforts that we talk about are really for patients who are ambulatory and have chronic heart failure with a reduced ejection fraction. We really have nothing for this growing population of patients with preserved ejection fraction. So when we talk about quality improvements in heart failure and either our wins or our losses, you kind of have to keep this in mind that we're really talking about a segment of the population, not all of the patients with it. Okay, so the last thing to just kind of provide an update. So I mentioned that you walk into any hospital in America, I think one of the first things that comes to mind for quality improvement efforts is really around some of the policy changes related to this. And some of them are shown here in this timeline. CMS has really been a major driver of this with a couple different efforts. They're shown here. So the first was a Hospital Compare, which is the website that patients can go to try to look at how hospitals are performing relative to other hospitals. Back in 2005, this just meant public reporting of things like process measures, like the quality of care provided to those patients. But over time, that changed to public reporting of hospital readmissions and mortality rates. And lately, these changes have translated into cuts in Medicare reimbursements. And so that's why it's gotten so much attention from hospitals around the United States. And I put this up in a heart failure talk, but as many of you know, this is also related to acute MI care and pneumonia care as well, and is kind of bleeding out into other areas, but is certainly an important part of any quality improvement effort in a hospital today. And one thing to think about is that this has happened rather quickly and happened in every hospital in America without a whole lot of data to understand what that means in terms of unintended consequences. So I'll talk about this slide a little bit. But one thing that we have definitely observed over the last few years, around the same time as a lot of these changes, is an uptick in heart failure related deaths. So these are data from the CDC. Without a great explanation for why this has happened. And I put this up next to the other public policy slide, not really to suggest that I think the two things are related, but there's very little data to kind of understand exactly what has happened as hospitals have started to adopt some of the practices to really focus in on readmissions with such vigor as they are doing. Let me spend a little bit of time going through previous efforts to improve heart failure care, and I thought a lot about this and had a lot of slides and cut it back because there are a lot of things that I could talk about here, but I wanted to kind of just focus in on two themes, and so I'll try to narrow it down just a little bit before we get into some of the current DCRI studies. So I included this the cycle of quality slide that I was thinking as I put it together. I wonder how many times this has been shown in this room over the years, as and for different disease states. But it's an important thing and really frames a lot of the quality improvement efforts that I'm going to talk about. So I know many people are familiar with this or a similar figure. This one's from a paper by Rob Califf. And it really highlights the kind of translation from a scientific discovery into a clinical trial. Those things are codified into a guideline, and then we talked about process measures and how that gets laid out into outcomes and then measured and improved. Something that we still are working on today, and it's hard to beat this figure. And when I think about trying to narrow down some of the heart failure quality improvement initiatives, I really think about kind of two things. One is this focus on process measures, and I'll talk about that and some lessons learned. And then two are a focus on some of the outcome measures. And for heart failure, what that really means is readmissions and mortality. We have very little data on quality of life in the real world setting. So let's talk a little bit about process or performance measures over time. This is a figure from a textbook that talks about some of the changes in inpatient heart failure process measures over time. I think one of the things that's important is if you're familiar with quality improvement efforts in other disease areas, there's often a pretty good link to the biology involved here. And I would argue that at times in heart failure, the link hasn't been as good. So a lot of the process measures that we looked at in the past were things like an ACE inhibitor, something with a very strong evidence for benefit in patients with left ventricular systolic dysfunction or a weak heart. And I think the evidence is fantastic for that, and that makes a lot of sense. But then there are things like discharge instructions where the evidence is much weaker, but was carried forward in a lot of different quality improvement efforts. And also, I talked a little bit about the different subpopulations of patients with heart failure. This is one of the things that was applied to all of them. And so any evaluation of the previous quality improvement efforts, you have to kind of consider that not all of these things have the best evidence behind them in terms of being a good performance measure that's actionable and has a good link to outcomes. The other thing about some of the process measures and the work around that here is that heart failure is very proud of the number of registries that we've had specific to heart failure over time. A lot of that work has been done here. I mean, at some point, almost all of these data have been affiliated with the DCRI at some time. And there have just been tremendous gains in terms of the improvement in the delivery of care over time. So patients and providers have gotten feedback on the care they receive. A lot of these registries have had educational materials affiliated with them. And then, the benchmarking relative to other institutions has really helped hospitals drive performance in some of these areas. But even though this has been going on now for, since early in 2000, there's still a lot of variation in care and disparities that we've noticed. And so, Emily mentioned this earlier. We did participate in a study to try to improve this within Get With The Guidelines. So I wanted to talk a little bit about that because it is a nice background into the Connect study that we're going to talk about at the end. So for those of you that are familiar with Get With The Guidelines heart failure, we're the analytics center for it, and so many of you work on it. But it is a quality improvement registry that's been around since 2005, and sites that participate in it get feedback on their performance for inpatient care related to heart failure. So it doesn't follow patients after they leave the hospital, but while they're in the hospital, they get feedback on medication use and some other important areas of care. And related to that, they also receive education materials and then some kind of guidance on how they might be able to improve the care if they seem to be lagging behind other centers. And so a number of investigators, I was lucky to kind of be involved in this at the end, but a number of investigators had ideas about how to make that more active and be more engaged in the quality improvement process to try to give sites more personalized feedback and to try to be more engaged with them as they went through the information and they worked with other centers to try to improve their care. And a study was designed that was a cluster randomized trial, so randomized at the site level, of many of the centers participating in Get With The Guideline heart failure. And as you can see, they ended up with around 150 hospitals and data on around 33,000 patients enrolled in the study. And the endpoint chosen was to try to improve the score that described the quality of care that patients were receiving. sure how well this projects, but at the end of the day, there didn't seem to be any improvement in an overall composite score of quality of care, despite the fact that there was pretty good participation in the newer feedback to sites. And I think I think there are probably two take-home points from the study. One, the fact that I think at the beginning most people would have said that seems like something that will definitely improve process of care measures and seems like a slam dunk. I don't know if we need to study it. I think that's probably wrong. I think this highlights the fact of how important it is to actually design a trial and get some data on what works and what doesn't work. The second thing is that it's feasible to do studies like this. There aren't a lot of studies that really go to the extremes of actually randomizing and collecting and getting information. And I think this is an extremely valuable service and really kind of pushes the field forward to try to understand what works and doesn't. I wanted to make a couple other comments about this kind of process measures and outcomes in heart failure, because it's a little confusing. And this is a really nice graph by Eric and Greg Fonarow from around 10 years ago now in JAMA, where they talked about the kind of dramatic improvements that were seen over really the decade of 2000 to 2010 in terms of the quality measures that I showed in the figure earlier. So things like discharge instructions, ACE inhibitor use, beta blocker use. And so if you just look at the pure uptake of these things, there were really dramatic improvements at hospitals across the US, a really remarkable achievement. But at the same time, we didn't see a lot of improvement in outcomes. On the figure on the right is a figure that shows that if you look at hospitals that participate and get with the guidelines heart failure, where you can clearly measure that hospitals perform better or on a lot of these measures relative to others, you see really only marginal improvements in outcomes. So the 3 dots here are related to readmissions, and the 3 dots here are mortality, where you really didn't see any difference there. So this is a little hard to understand, I think, at times, and it's hard to know if it's really the process measure that's the problem or whether there's something different about heart failure care. I can say as somebody who recently went through heart failure training, and I told you there are a lot of new therapies. Heart failure care can be pretty complex, and we definitely we oversimplify it into little buckets. Often just by ejection fraction. And so I think it's probably both, that we don't have perfect measures, but at the same time, it's a pretty complex disorder, and there are a lot of moving parts involved. Let me give you one example of what I mean by this second part. This is around transitional care, some work we did in Get With The Guidelines. Many of you are familiar with, Adrian published a paper in around 2010 with some of you in the audience, showing that hospitals that had the lowest rates of early follow-up after discharge, so when a patient's discharged from the hospital to home, and have some follow-up with any provider, those hospitals that had the lowest rates had the highest readmission rate. This got a lot of attention and is actually incorporated into the guidelines for better quality of care, that patients should have early care. They're a really impactful observational study done here. And in fact, we looked a few years later, and if you look after this paper was published and incorporated in the guidelines, if you look in the blue line at the top, hospitals really started to increase their use of trying to make sure a patient had a scheduled follow-up at the time of discharge from the hospital. So these are patients, when they would leave the hospital, had an actual time and date for a follow-up visit related to that hospitalization. And you can see just in a few short years, it increased quite a bit, which is a pretty remarkable achievement. So improvement on a process measure. We actually think we were pushed by the journal, but we had the idea to then go look and see how many of those patients actually made it to the appointment. And it's actually any appointment. So if you focus on the bar graphs on the left, these are all patients who left the hospital with a scheduled time and date for a follow-up visit within 7 days of discharge. And the blue are the people that showed up to anybody within 7 days where a bill was submitted to Medicare. And the red are people who didn't make it to any visit at all. And then in the yellow-green are people who died or were rehospitalized. And you kind of get the sense that while we have the idea that we're providing really high-quality care, we're going to the extra mile of trying to schedule appointments. There are a lot of other things that are much more complicated about this than simply kind of filling out the forms and going through the steps. Yeah, and I think these numbers are pretty humbling, that even if I promise you, as somebody who routinely rounds in the hospital, not every patient leaves with a visit. And even among those, and among the Medicare patients with insurance, and probably the more frail of the patients we take care of, less than 33% of those that were able to actually keep the visit. Makes you think twice about some of the advice that we give patients and some of the care we think we're providing. And it also gives you a sense of a lot of the other domains that happen after people leave the hospital. I'm going to kind of return to that theme in a little bit, that we have to consider if we're going to try to move the needle on care. So let me talk a little bit more about outcome measures. And I mentioned this, that I think some of the policy changes that CMS has implemented have really driven quality of improvement care in the US in the last 5 years. So this is that same timeline I showed earlier of some of the steps that CMS has made to try to improve care. And I want to focus on the middle one for a second. So in 2009, CMS made a public reporting of readmissions for hospitals available to patients so they could compare, Duke versus UNC and try to get a sense of what type of value they're receiving. And we had the question, does public reporting improve outcomes at all? I mean, this is hospitals became intensely focused on this and made it, one of the most important parts of their QI efforts. And if you look at the graph on the left, on the first half of the box are the actual readmission rates, and on the second half, the dotted lines are what would be predicted based on risk adjustment of the patients in hospitals. And then red is what we actually observed after public reporting began. You can see there's basically no difference there. But if you look on the right side of the screen and you do the same thing for 30-day mortality, you see a little bit of a concerning change in terms of upticks in mortality over time there. And so again, I think we really have to think about some of the unintended consequences of some of the policy changes, because they happen in every hospital in America. Maybe the one, though, that has the most impact is the one at the right side of this. So in 2012, CMS began actually withholding money for patients that had higher than expected readmission rates. And just now, data are starting to come out to give us a sense of whether this actually had an impact or not. So this is a paper that was published a few months ago in the New England Journal. And there are a few other analyses that are kind of similar, looking at did these penalties and readmissions actually change care? And again, they've all kind of focused around the readmission. Did they move the needle on readmissions? And the answer there is yes. So if you look at this, they broke this up into 3 time frames, where on the left side of the screen are prior to the announcement of these penalties. In the middle of the screen is where between the announcement by Obama and his administration, and then before they actually took effect. And you can see people seem to have responded in terms of their readmission rates. Though again, I'm not sure we know all of the other changes. And so I think that in general, this is a really big driver of what hospitals are reacting to now. And I'm not sure they're always data-driven and the most rational policy decisions. And I certainly don't know about kind of rolling them out all at once around the hospital. So I like some of the demonstration projects, and we're involved in some of the analyses to look how successful those are. And I really think that's going to be helpful as we move forward here. Okay, so I promised that the point of this talk was to talk about some new DCRI initiatives, and then I want to bring Linda up. So let me go through those. There are many different things I could talk about here for things that we're doing in heart failure care, but I wanted people to be aware of at least 3 of them. So one of them is the CHAMP-HF registry, which is a Novartis-funded registry. It's really focused on outpatient care. So they're making one of the new drugs that I talked about earlier. And I'm excited about this because it can move the needle to get out of the hospital and thinking about outpatient care, which we haven't done as much in terms of quality improvement in the US. There's also a really big focus on quality of life and some other outcomes that we haven't looked at in other registries. And we are the analytics center here. Lane Thomas is the PI for that. So it'll be a large project that you'll be hearing more about in the future. Another study, so I mentioned ivabradine was one of the drugs that was recently approved, is the PRIME-HF study. We're looking at the implementation of that drug in the US. I mentioned this fact when I went through the slides, but there are really no data on the use of ivabradine in patients from the US. And so I think PRIME-HF is going to be a really important study and is focused around implementation and some of the challenges associated there. Rob, who's in the audience, is the PI for that study, and we recently enrolled our first patient, which is fantastic. Yes. And so you'll be hearing more about that as well. Rob, anything else you'd say about that? Okay, good. All right, so let me end by talking about Connect, and would like to hear your thoughts and questions about that. So I went through a little bit of the history and some of the other things about quality improvement efforts in heart failure, and I think one of the things that's apparent is that there's a real division between the hospital and home. And very few efforts have tried to systematically bridge that gap. So certainly, a hospital may have a QI effort just at Duke or at other one health system where they're looking at both, but very few of the national efforts have tried to do both. And so Connect-HF is a quality improvement study that is going to try to do both. So we're going to enroll patients in the hospital as shown in the figure here. And the interventions, and I'll talk about those, are going to follow patients over the next year. And we're going to include outcomes from the call center here. But all of the interventions are designed to kind of start in the hospital and continue on as opposed to just living in these isolated areas for the patients. We're going to look at two different quality improvement interventions, and they're very different, but I think both are very interesting scientifically. So the first is what we're calling a direct engagement, and the idea is to work closely with the hospitals to try to improve the care both at the time of discharge and then the transition to home, and hopefully to follow them over the next year. And a lot of this is really kind of building upon some of the things we talked about in the Get With The Guidelines study to really take it to the next level and to borrow from some of the successes from the ACS studies that have been done here, as well as the AFib studies by Chris Granger and his group. I see Mamie's in the audience, she's done a lot of work on that. And try to learn lessons from those studies where actually, getting out to the hospital and working with hospitals, working through cases, working with their individual problems has been dramatically successful in trying to organize care at those health systems. So that's one big part of this. The second is trying to engage the patients in a different manner. And I don't know of any large quality improvement efforts that have done this, but we're calling this digital engagement. So Zubin Epen is helping us a lot here to try to help patients through different mobile applications. And one is just some simple stuff of trying to help patients with appropriate education in terms of their medications and nutritional status and so forth. But a second aspect of this includes some behavioral economics techniques from Dan Ariely's group of trying to change the way patients are rewarded and engage with these devices to see what we can learn from that. And I've got a nice figure here to talk about some of these. So the two prototypes that we're hoping to use in the study are HealthStar or Fabulous, which are two different mobile apps that we think will allow the patients to kind of think about their heart failure care differently and specifically try to get some feedback on the care they think they're receiving and the way they engage with their providers. And one of the unique aspects of the study, and would love to hear your questions or thoughts on this, is that we set it up as a 2x2 design. Again, a cluster randomized trial like the Get With The Guidelines study that I talked about earlier, to try to be able to look at these two different types of interventions individually. So let me walk you through this figure. We are calling, we're basically setting up a large U.S. registry at 160 sites, hoping to enroll 8,000 patients. And so the usual care in this arm is referred to as the Connect-HF registry. The digital piece that I talked about is shown there in the blue boxes with orange around it. And then the hands-on hospital engagement or health system engagement is shown in the green here. And the outcomes that we're looking at are, one, we want to look at clinical outcomes, so heart failure, rehospitalizations, and death. And that's how we're powered here. But we also are going to have a process measure score that uses some different quality of care measures, and we'll follow the patients over the course of the year. These are the enrollment criteria for the hospital, and the take-home point I want you to see here is that they're very streamlined. I'll show you the patient inclusion criteria. It's the same thing. So for hospitals to participate, they only need to enroll admit 50 patients annually for acute on chronic heart failure, and then have the capacity to be enrolled to this direct engagement strategy. And for patients, again, very streamlined inclusion-exclusion criteria. We're hoping to get some very real-world data here, where patients basically need to have a reduced ejection fraction and not a lot of other comorbid conditions, but a very easy inclusion-exclusion criteria. One other, at least unique aspect for me of this study is including patient representatives. And so this has been a really fun process for us. We've learned from some of the PCORI projects and other initiatives here at the DCRI that have done this really well. And they've provided a lot of feedback as we've put the study together in its initial phases, and then we are planning to engage them quite a bit as we roll out the mobile applications. And Linda, if we have extra time, can tell embarrassing stories about some of our interactions with them. But they really remind us about what it's like to live with heart failure care, or live with heart failure, and keep us kind of grounded in it. And even I go to clinic every week and see patients with heart failure, but having them involved in the study is an important reminder and has been a great experience so far. The other thing we're hoping to put together, and we could probably use some work on the branding, is some type of academy or set of quality improvement leaders in heart failure, really with different backgrounds. So some would be heart failure providers, but also just people interested in quality improvement in general, and want them to be a part of the study as well. And so we're working on that. Let me end, and then we can take some questions about the Connect study. So just kind of conclusions from the talk. As I mentioned, I think improving heart failure care is a really important public health problem. Of course, it's important for patients, but also important for the rest of society in general. And while there are a lot of new treatments and options for patients with heart failure, a lot of those are centered around patients with heart failure with reduced ejection fraction. But there's this growing number of patients with preserved ejection fraction that we need better evidence for. And I think if you look through the last 2 decades of quality improvement efforts in heart failure care, 2 of the major dominating factors have been, one, disease-specific registries, largely driven out of here, and then 2, some of the recent public policy efforts that are really dominating the landscape today. And then I talked a little bit about the 3 new studies that I'm excited about here, and I hope you're going to hear more about here in the future. And thank you guys for coming. And then, like I said, I wanted to end by having Linda come up and kind of talk a little bit about her perspective and let you ask questions about that. So thank you. Emily, can I steal the microphone?
Yep.
Thank you.
Okay, so my perspective on this, I think what we're doing in Connect Heart Failure is basically bringing together all the pluses, all the things that we've learned so far in how to do a clinical trial, how to handle registries, how to engage patients. This one study is going to be probably the pinnacle study, the study that actually shows the world, hey, you can involve patients, you can involve advocates, you can take this one step farther. So that's what I see. This is going to be interesting. So far, it's been complicated. And the reason I say it's complicated because of all the things that you mentioned. So we have the clinical registry piece. Let me just back it up. Let's start with identifying what type of study this is. Okay, so when we first started, I thought this was going to be a clinical registry. Then we had discussions, and we found out, no, maybe it's going to be a clinical trial. Finally, we came to the conclusion that this is an investigator-initiated study. So we all understand what that means. That right there changes who is the sponsor. DeVore is the sponsor of this study. Okay? Novartis is the funder. So in our interactions with Novartis, it's very important that in the protocol, in the contracts, you never mention them per se. Okay? So the buck stops with Adam, so to speak. So now that we have that defined, even though they are the funder and not the sponsor, there's a great deal of negotiations that go on with them because the price of this initiative is larger than what they've ever encountered in an investigator-initiated study. Now, what we've had to do is go through all the pieces and say, look what you're getting. This is not your simple investigator-initiated study with maybe 500 patients. 160 sites, 8,000 patients. You have the QI initiative. We're creating this QI Academy where we're going to have to bring these heart failure and other physicians in to train them how to be trainers for the sites regionally. So we've gone through all this, and I think they're now on board with the concept. They're in agreement that this is something that's very needed. Their drug is on the market. It's FDA approved. So we're working our way through it. My hope is that maybe by January, we will have our first site activated. What are the concerns that I've had? One of the main concerns is understanding the whole app piece. You know, we're always talking about mobile health. How do you incorporate it in studies? I've worked with PIs where we've had different pieces added. We've had a portal added in one of our studies. But how do you go from that concept to having a group, Pattern Health and Fabulous, actually bringing an app, developing an app for this patient population?
Yeah, I was just going to echo that. For me, I do a couple different things in this kind of pragmatic trial space, and it seems like most trials that we do, and a lot of patient interactions I have, people are interested in mobile technology and what those things can do. And so the same themes keep coming up. So a lot of the pragmatic trial work, it's always the same kind of concerns about safety and monitoring. I mean, I feel like that comes up on every one of these trials. You know, Rob, we had the same thing with Prime, and then for the mobile health pieces, it's it's a big change to go from something that's in the commercial space to something that can be part of clinical care, and a lot of the regulations around that, we're still figuring it out.
So one of the things I do want to mention, because I'm speaking mainly from the operational standpoint, is you begin to understand all the different areas here at Duke. And when I speak at Duke, I mean big Duke, not just the DCRI, and all the different people who need to be involved to help make your study successful. Okay, so we're talking, of course, contracts and IT and ISO, and you get to meet a lot of people when you have a study like this. And you get to understand what the rules and the regulations are to make sure that you're covered and protected. Not only are we protected, but also that we can ensure that our patients are protected. So part of our study requires that all of our patients have a smartphone. So when we're thinking about, okay, so how do we actually put this app or have the site coordinators to download the app onto their smartphones? So one of the things we were thinking, okay, coordinator, you pick up the smartphone, you put the app on, tell the patient all about it, life is good. So one of the rules is that the study coordinator can never hold that patient's phone, because that phone belongs to the patient, does not belong to the study coordinator. So simple little things like that from a learning perspective are very important because we're the ones who's training the sites. So Adam did mention that we have the call center. After the patients are discharged from their enrolling site, we, the DCRI, become, I'll call it the site of record. So we're the ones who are going to follow these patients. We're going to find out how they're doing. If any issues come up, then we will make sure that the patient reports back to their enrolling physician. We're going to be collecting, the call center will do the calls. We'll have someone who's collecting hospital bills so that they can do event validation. We've had great papers written already on that concept. I like a challenge. and this is going to be a challenge. So I'm going to just say, do you have any questions? We've been doing this a while, so I think we're prepared to answer some questions.
We're prepared to answer. I don't know if we have answers to the questions. They're two different things.
2x2 design. No, it's I spend a lot of time over at Crowsdale these days with my mom, who is 91 years old, and I see that the young old have smartphones and know how to use them and everything, but the old not so much. You know, I've been trying to teach my mother to use her iPad for 5 years now. So you have this whole digital component here with the assumption that these people with heart failure are going to have smartphones and going to be able to use them. But I'm assuming that what are you going to do to make sure that you don't end up with the young in the digital side and the old, no, it's the young old in the digital side and the old predominantly in the non-digital side?
Yeah, that's a great question. We got really worried about this, and I've tried to think through it. We are going to have, so every patient who enrolls has to download something onto their phone. So even in the Connect HF registry, they'll download an application that talks about the study, has heart failure education materials as part of it. And if they're not able to do that, or a family member's phone, then they can't participate. So even if it's just the registry part. And so that's how we're going to try to protect against that bias. But I think the overarching part of your question is really good too, is like, is this really the need that people want? You know, is this something that we're thinking of a 50-year-old who does everything on a smartphone, or are we really thinking about heart failure patients? And that's, for me, is where the patient panel has been fantastic. And, you know, they were they came from being volunteered by people from the steering committee, but they've been fantastic about trying to remind us exactly what they want to do, and we have gotten some pointed feedback that we were on the wrong page early on, and so we've learned a lot from that process, and we're hoping as soon as contracts are finalized to bring them to Duke and really go through a hands-on learning session to try to get more feedback from them about this, but it's a really important point.
And we've also gathered some data from previous studies, specifically Artemis. So the assumption was that the old, and maybe even some of the young old, would not use any type of devices at all. That they, for example, for the call center, that their preference would be, call me. No, I don't want to go out on the web. I don't want to answer questionnaires in that fashion. So that was our assumption going in, and we were wrong. There are a lot of patients who are, I would say 80 and above, who chose that method. They didn't want to be bothered with the phone call. You know, I had to flip. So I always thought, oh, they would love for you to give them a call. No, they didn't have time. So, and maybe the difference is because she's in a nursing home or live-in assisted home. I just don't know. But we had patients in Artemis, 99 years old, who was, you know, filling the form out online. So I don't know. Any other questions?
Thanks for a great talk. Yeah. I was just curious, like now that you have the capability of collecting a lot more data, maybe through an app or digitally, how have you kind of decided, in terms of the granularity of data you're collecting, or how frequently you're collecting it? Do you use patient feedback or?
Yeah, it's a good thought. So remember, these patients are going to be interacting over the course of a year. There are a lot of different opportunities here. So one thing that we are allowing is that it's going to modify over time, the applications, and that we will be collecting some data on those patients, but none of that will really be used as part of the endpoint assessment, because we don't expect that the patients in the usual care or the registry part would interact with their phones as much. And so I think we'll learn a lot about activity and use of mobile applications when people leave the hospital, but we're not going to use it as part of any of the hard endpoint assessments. Emily?
So I really liked your comments about the sort of dichotomy between using process measures and outcome measures to measure quality. It sounds like you're an advocate for looking at both, since you have two co-primary endpoints.
All right,
there.
good. You picked up on it. No, I think that's the right answer. Yeah, it's not one or.
But I do have a question about looking at quality metrics, and again, maybe this is why outcome metrics were also included, and I'm curious about your work with the prior cluster randomized trial. Given that this is based in a registry and that the sites who volunteer to participate in such a registry are likely different from sites who do not, and those of us who are familiar with these data know that quality is actually already pretty high for a lot of them. How concerned are you about site selection there, and how generalizable do you think your results are to sites who don't participate in these volunteer registries and are just still treating heart failure patients but in community practice?
Yeah, that's a really important point. If you get with the guidelines, it's about 600 hospitals, but there are about 4,000 in the U.S. We're going to talk about 160 here, and I'd say our early interest in the sites, there's a lot of enthusiasm for this, but how do we know what kind of hospitals they represent? It's a great point. So one of the things that we'll have here is a pretty detailed description of what the hospitals are. Like we put them through a bit of a battery to try to understand what kind of hospital it is, and I think it'll give us some information to be able to compare them to others that I think will be important to understand about generalizability. But you raise a really good point about that. Other questions? All right, well, thanks everybody for coming. I just wanted to say, I've been on staff now for 3 months. And it's been, yeah, exactly. Thanks, Adrian. I can't say enough of just how excited I am to be here, and it's fantastic. So thanks everybody, and looking forward to working with all of you.